Good evening. I'm Dr. Max Gomez, Senior Medical Correspondent at CBS 2 here in New York. And it is again my pleasure to be moderating an ongoing series of webinars from Columbia University Irving Medical Center. Tonight's topic, a breath of fresh air, treating children with allergies, asthma, and cough. And here to introduce our distinguished panel is the Chief of Pulmonology, Dr. Meyer Katan. Meyer?
Thank you, Dr. Gomez. I'm pleased to introduce our distinguished panel, who will be talking about common respiratory problems and things that you see in pediatrics that present really are of great concern to the parents and sometimes cause some problematic issues which are difficult to deal with, and we'll try to answer all your questions. Adriana Matisse is a general pediatrician who has done a lot of community work, and especially with regard to asthma. Anu Malapati is a pediatric allergist, and Susanna Hills is an otolaryngologist who also works in our aerodigestive clinic, and Stephanie Levinsky, who's a pediatric pulmonologist, who will be assuming the directorship of the division in July.
Very good. Boy, knocked my microphone right off. All right, so welcome everybody. I think this is going to be really interesting. We have some, I think, very important information to convey here. So let's start out with, before that, let me do a couple of housekeeping things. We will have sort of a companion piece and summary of some of the information that we'll be presenting today. We're also recording it, and it will be available on our YouTube channel after it gets posted in a few days. So if you miss something, it'll still be there. So thank you. Let's start out with the basics. A child comes in, they're coughing, they're wheezing, and it must be asthma. Or maybe not. Meyer or Susanna, what do you think? How do you figure this out?
Well, people say, my child is wheezing. My first question usually asks, what's wheezing? And it's noisy breathing to some people. Not all wheezing is the same. So first we have to figure out what the problem is. And then we try to ask questions that if we think the history is suggestive of asthma, try to get points that may increase the probability that the diagnosis is asthma. And Susanna, a lot of patients come to you. Usually it's sort of cough or noisy breathing or whatever, but how do you approach it?
Yeah, I've seen a couple of these in my clinic today, Meyer. So I think everything that we're going to hit on in this talk came to my clinic today too, and probably at least half of them were seen by Pulmonary prior to coming to me. So we work together on these diagnostic challenges all the time. And I know how Meyer approaches this because we're both in aerodigestive clinic together, and we tend to ask very similar questions. But the pearls that I think are helpful for people to take with them are just, first of all, the concept that cough is actually a pretty complicated response. And it has to do not only with the respiratory tract, but especially in kids, it can have to do with the digestive tract too. So the fact that you have two different systems that can work independently or work together to create this wheezing cough picture is, I think, what makes it so challenging. So I'm often asking questions about how the cough sounds, just like Meyer just said, how long the child has had it. If it's something that's very, very new, that's different than something that's been happening for years. I ask if they have other symptoms of, for example, reflux or digestive issues, because having reflux problems can trigger a chronic cough. If they've recently had a cold and that precipitated a cough that just won't go away, then that too is, an important piece of information and might suggest underlying reflux exacerbating, that's maybe silent, kind of exacerbating this cold-induced cough. And Meyer and I see that together a lot, a cough that's kind of maybe lingering after a cold for a few months, and it might be due to a chronic irritation like reflux. So I want to know, how long it's been going on for, what the noisy breathing or the cough sounds like, and what might make it better or worse, or what triggers the problem.
So, Meyer, Susanna mentioned digestive tract and aerodigestive. How common is reflux in children who present this way? And is it truly asthma, or is it reflux that's triggering this cough, or is it reflux that can trigger asthma?
Yeah, that's a difficult problem. I think that reflux probably is overdiagnosed, but I think that one has to ask if there's some abdominal issues, if it's a baby, if they've been spitting up a lot, if they're choking on feeds. And it's difficult to diagnose and to know whether the reflux really is causing the symptoms. People have reflux, babies spit up. They don't necessarily, and all end up wheezing or coughing. So it's a challenge. And I want to ask Susanna, how do you diagnose reflux?
Well, I would echo exactly what you just said. My feeling is that there's a degree of reflux, I think, in almost every pediatric patient. Probably every person has some degree of acid that occasionally comes up from their stomach. And the smaller we are physically, the younger kids are, the more closely related their digestive tract and their airway are, because they're so small. They're very close together. And the things that separate them, the muscles that separate them, are a little bit smaller and not as strong when kids are infants. So then the question is, if you kind of assume that, all right, every baby's going to have some reflux and going to spit up a little bit, every child will have occasional episodes of reflux, when is it a problem, or when is it a pathology? And it's easy when somebody says, my child is spitting up, vomiting, they have, pain after eating certain foods that seems like, heartburn. Kids who are older can explain that they're feeling that clearly too. That's helpful. The tricky part is when it's this silent reflux that has some other symptoms, like maybe chronic throat clearing, chronic cough that tends to be worse maybe after lying down all night because they've had acid there. So then the history, you kind of have to get into some subtleties of the history and figure out, is the reflux really a problem? And sometimes the reflux isn't a problem at baseline, but if, for example, that case that we see a lot of after, during the winter, where somebody got an upper respiratory tract infection and that cough goes on forever and ever and ever, it's lasting for 3 or 4 months. They have a history in the past of having reflux, or they have other symptoms of throat clearing that are mild and they have reflux. Sometimes it's worth managing that like reflux for a little while they have that cough problem for a month or two and seeing if things resolve. But the question is, when is it causing an issue for the child?
So let's talk now about some different triggers. Anu, we're in springtime, and allergies, I keep hearing from people that they're having a tough time with allergies. How do you distinguish between allergies, the coughs or the wheezing that might be that, or allergies that are actually triggering real asthma?
So allergies are certainly in the differential diagnosis of someone with persistent cough. With poorly controlled rhinitis, people have nasal congestion, postnasal drip that can give people this cough that never goes away. So when I see these patients that present with cough or complaints of wheeze, I often will do environmental allergy testing to identify, is it really a trigger causing the symptoms? Also, in conditions like asthma, environmental allergies are often a major trigger. So being able to identify that puts us in control to be able to take action, whether it's with environmental precautions or avoidance strategies, or even it helps us better treat patients if we know exactly what the cause is. So for patients like now with springtime allergy symptoms, you know, it's probably the tree pollen. So giving them advice about what to do in terms of closing the windows when it's a high pollen count day out, or changing clothes before going to bed, taking a shower at night to wash that pollen out of their hair. Don't put your clothes outside to dry during the high pollen times. Little things like that sometimes can make a big difference with small strategies and just knowing what you're dealing with.
Is it possible that either with reflux, as Susanna was talking about, or with allergies, that you sort of do a test run with a medication that might help either with reflux or with the allergies, and see how that does for the child, to see if that helps?
Yes, absolutely. Oftentimes, especially once I identify that there is an allergic trigger, I'll do things like nasal steroid sprays, which are good treatments for allergic rhinitis. And if we try that and nothing is improving at that point, then you have to think of maybe there's another cause that's causing symptoms. Or if we do testing and there's no allergic sensitizations and nothing identified, then you know at that time too that it's unlikely to be allergies, at least, that are causing the symptoms.
Adriana, Anu mentioned environmental issues, so I want to come back to that in 1 second, but because she also mentioned inhaled corticosteroids. And Stephanie, talk to us a little bit about what are some of the guidelines these days for treating or intervening here?
It's a great question, because actually just at the end of 2020, the National Heart, Lung, and Blood Institute, they have an expert panel review that actually came out with some updates to the guidelines for management of asthma. And it's been 13 years since we've gotten an update on those asthma guidelines from the National Institutes of Health.
Wow.
But they really focused on 6 specific areas in terms of where they offer new guidance. And I can just run through the list of them. They include the use of fractional exhaled nitric oxide, which is a biomarker we use to identify airway inflammation. They talk about inhaled corticosteroid use and how to different new ways of managing that are sort of outside of the paradigm that we're used to. They've added long-acting muscarinic antagonists as part of the treatment regimen, allergen mitigation strategies in the environment at home, as well as in Anu's area, sublingual and subcutaneous immunotherapy. And then lastly, they talk a bit about bronchial thermoplasty. So I think the guidelines, or the newest recommendations in terms of the use of inhaled corticosteroids, are probably the most relevant for this audience. Some of the key points there are, for one, in children who have intermittent symptoms that are younger than 4 years of age, the guidelines now recommend that you can use a short course of inhaled steroids around the time that the child has a lower respiratory tract infection, to sort of decrease the need for systemic steroids in those patients. This single-use maintenance and rescue therapy is a new guideline recommendation, where we are so used to telling patients that they should use an inhaled corticosteroid or a long-acting beta agonist as a controller medication, and then a separate pump for when they're having asthma symptoms. But now the guidelines recommend using a single inhaler for both control of symptoms and as a rescue. And they also recommend using as needed inhaled steroids and medications like albuterol, which is something that's new that we haven't seen before in the guidelines.
How do you get an infant to use an inhaler?
Well, for infants, we often use nebulized treatments. And so there's sort of an age threshold. I personally find that in the smaller infants, or the smaller children, it's a little bit easier to use a pump with a spacer, and a spacer that has a nice fitting mask. It's quick, it's much easier than a 15-minute nebulized treatment. So we have our ways and our tricks and our strategies we offer to parents.
I'm sure you do. So Adriana, we've been talking a little bit about different triggers, and something that's especially, I guess, top of mind in urban areas and in New York are so-called environmental triggers, triggers at home that are not reflux or even pollen allergies, for example. What are some of those, and what do you recommend? How do you intervene and try to make a difference there?
Sure. So I think one of the leading ones that we talk about with our families in the office is things around exposure to secondhand smoke, roaches, dust mites. In our urban environments, roaches is a big conversation, rodents as well. And here it sort of ties into what Stephanie was talking about with the guidelines. The guidelines are a bit more forthcoming with their recommendation around being really more targeted in our approach with our advice around mitigation. And I think this is a key difference. So when I trained nearly 20 years ago, we were under the sort of in our practice, we would say to families, just blanket, get a pillow cover, get a mattress cover, and that would be helpful. And really the guidelines this go around are a bit more specific. They really highlight that we need to identify children who are symptomatic, so who are having signs of poor asthma control, children who are exposed to the allergen, so are they being exposed to dust mites, for example, and have they shown sensitivity maybe with allergy testing. So identifying that discrete population and then implementing a multimodal approach to that mitigation. So not just pillow covers and mattress covers, but thinking about maybe potentially a HEPA filter and bringing that into the home environment, or working with integrated pest management to reduce the allergen in the environment. So really it's much more targeted and more focused. And I think that's in a sense, a breath of fresh air for the guidelines, because there's a lot of burden on families if you just say, blanket, go do this. Not everyone can do everything. But if we're targeted and we're really finding children who are sensitized and symptomatic, I think it's clear.
So when you say sensitized, you would test the child for sensitivity to some of these environmental allergens?
So we wouldn't. And actually in our practice, we don't test. We actually refer them to our colleagues either in pulmonary or allergy, where the approach can be more targeted and thorough. I think the reality is in general pediatrics with a 15-minute visit, it's very hard for me to really understand the approach that I should take into implementing really a thorough evidence-based evaluation. And so really referring to our colleagues is much more targeted and I think beneficial in the end. We're not doing 10 blood draws for families and making things inconvenient and uncomfortable. Whereas if I send my patient to a NU, she'll be very targeted with her ability to get a 45-minute history and really understand the patient's circumstances.
Have you found
I think what's
go ahead, Meyer, please.
Yeah, I think what's important from this conversation is that certainly with asthma, it's not one thing. There's no one magic bullet. Usually it's multifactorial. It's rare just to be allergic. The most common triggering factor are viruses. Some people it's allergies, some people it's exercise. It's unusual just to have exercise-induced asthma. You should be suspicious that somebody just says the only symptom they have is, in the absence of allergy or some other symptom, or like prolonged coughing with colds. So, and then you can target it. Then, you can say maybe this patient has more an allergic problem, and we would send it to the allergist. This patient may have more other issues that are triggers, whether to refer to ENT or pulmonary or to allergy. So I think, the history is crucial.
And I think along those same lines, I was going to add, I think the guidelines also focused a lot more on bringing the patient into the decision-making and shared decision-making model in terms of how do you manage asthma. And I think what we're seeing here in these updates are that the therapies are, the recommendations are a little bit more aligned with what we think our patients are actually doing. I think it's, there are several patients who are not taking controller medications every single day, despite the fact that our recommendations prior to this have been that they should be. So I think the guidelines now sort of allow us to tailor our treatments a little bit more to what we think the family actually is capable of doing, wanting to do, and invested in doing.
Real world interventions are so different. We hear so many things, or you should be doing this, this, and that, and in the real world, that's not always possible. Let's go back to allergies, though, Anu. When do you escalate, say, to actually either doing the allergy testings that we were talking about a little bit with Adriana, or even go to the point of, subcutaneous immunotherapy, what commonly is called just allergy shots for kids. At what point do you move sort of towards the nuclear option, kind of?
Right. So I think this goes along to the point that Stephanie was making. It kind of depends on what the family prefers and what will work best and how the symptoms are generally. I have some patients who just don't want to take medicine, or who won't take medicine, or are having side effects to the medicine, or even with optimal medical therapy, their allergies are still just very poorly controlled. And I think in those kind of patients, immunotherapy is a really good option. Subcutaneous immunotherapy is definitely a good option for patients for whom allergies really play a prominent role. It's effective. Patients report less symptoms and medication use after starting. And a beneficial part of it is that it can treat multiple allergens at the same time, which is a nice thing. What we essentially do, or how it works, is we administer what the person is allergic to in different extracts in progressively higher doses. And the goal is to really induce tolerance to that allergen, because we are giving them something that they're allergic to. There is that risk of potential serious adverse effects, but it's not common, and we monitor patients carefully after injections for those kind of symptoms. And that's another reason why it's important for asthma to be well controlled before starting something like subcutaneous immunotherapy, to minimize that risk. There's another type of immunotherapy as well that maybe is less known, sublingual immunotherapy. That is an option if you have a patient that has specific allergies, like they're allergic to dust mite, grass pollen, or ragweed pollen. It's available for those allergens specifically. It doesn't involve injections. It can be done at home. So it's really patient specific what the best option is for that. With the dust mite tablets, the indication is 18 and up. So for our pediatric patients, that wouldn't be a good option. For others, it might be.
Got it. So Susanna, I keep hearing as I cover a lot of these different issues, particularly with asthma, that we shouldn't be seeing kids, certainly, or even adults, dying from asthma attacks, that we should be able to control most, if not all, asthma. Is that realistic, and is that your belief?
So personally, I tend to get called with cases of asthma when it's super severe and these kids are in the ICU and they're wanting us to do an airway evaluation. But that's really rare. And the pulmonologists on the panel can also add their thoughts on a deeper level. But to me, yeah, I feel like with the right plan, and with what Stephanie was saying a few minutes ago about plans being adapted to what families can actually do and what works for them, asthma should be one of those diseases that's impacted kids so negatively that we really should be able to control and help kids thrive and help keep them out of the hospital. And we've got medications and treatments that can achieve that. But what do the rest of you guys think? Maya, Stephanie?
Yeah, the goal of treatment is that, or what we tell the parents, is a child with asthma should be normal. That's the goal. They should be able to play. They should be able to run around. They should be able to keep up with their peers, and they shouldn't be coughing for 3 weeks with every cold. That's not normal. And, and if we can prevent those symptoms, we usually will be able to control we reduce the risk of having more severe episodes of asthma. And the other thing to remember is that people who are not doing well, we have to make sure that we instruct them on how to take the medications properly. I think that many patients really don't get adequate instructions on how to use these inhalers, whether it's the nasal inhaler, whether it's the oral inhaler, the asthma inhalers, how to use it and when to use it. And we need to go over it each time. It's amazing how many children will be making mistakes and they're not taking it unsupervised.
It's a lot, in some ways, it's a lot like diabetes, I guess. The educational component particularly in asthma, I think has been underrated or underestimated in terms of its value. And it doesn't just take one session, right? It's something you've got to keep
It's something you have
going
to keep
back and back.
repeating.
Yeah.
And, you know, you would be amazed at how many people take the nasal inhaler wrong, incorrectly. And treating the nasal symptoms is as important as treating the asthma symptoms, because people who have the nasal symptoms often have worse control of their asthma.
Interesting.
I agree completely. I think that's to Adriana's point earlier about how, you know, we as subspecialists can be super helpful because we have a little bit more time to focus our attention on these very specific problems, whereas as a general pediatrician, there's a lot more ground to cover in a shorter period of time.
Max, the other point that I want to just add is that we often find that families who are struggling with social circumstances find it extremely challenging to use the inhaler correctly, to pick up the inhaler, to go to the pulmonology appointment. So all of these other things cascade. So the essence of sort of the root of the issue in many of our families, both in urban and rural areas, is really more around the social aspects in their household that are competing with their ability to focus on their child's asthma. And that's where partnership with community health worker programs, local resources around peer support, parent advocates, those can make a tremendous difference in those families' lives.
That's actually, I was going to ask that is, there's a role then beyond the medical professional, the physician in this, particularly in these environmental issues, to bring in, whether you call them social workers or community health workers or whatever. How or when do you bring them in, and how do you do that in a way that doesn't seem judgmental or pejorative, that people will say, well, yeah, you think I'm, you know, I live in a dirty home and that's why you're sending people in. How do you handle that kind of a situation?
Sure. So I would say part of that really begins in the office and building trust and getting to know families and really being open and listening to their story, and building that relationship along a continuum. And they may not tell you at the beginning that they're about to be evicted or that they're, you know, they have a kitchen with a non-working stove. They may not tell you that because they might fear multiple things, that maybe you'll call the Administration for Children's Services or, you know, the child welfare agencies. So it's building that trust over time. And then hopefully if they're able to tell you, or maybe they tell some member of your healthcare team that they trust, maybe it's your medical assistant, your nurse. Once you gather that information, it's looking for resources in your local community. And that may look different depending on where you are, but either through the departments of health, through local community agencies, around the country, these organizations are available to connect families to resources. We definitely don't have you know, we're not overwhelmed with these resources. There's a paucity in some of our areas, but there is a growing movement around the country to provide this to families because we understand that that is often at the crux of the issue.
And I'll just add to that. I think one of the most useful resources I've found for patients that, you know, are a little bit harder for me to reach or maybe having sort of broader concerns are school nurses. And really medications or treatments implemented in the right way. So when I'm sensing there's an issue in that way, just reaching out to the school or the school nurse to try to have them get looped into also supporting the family can be really helpful.
So Stephanie, you mentioned a couple of things that sort of piqued my interest earlier. Tell me about, you called it exhaled nitric oxide testing. What is that and what can it tell you?
Sure. So fractional exhaled nitric oxide is a biomarker. So nitric oxide gets increased in the airways when there's inflammation. And we have a device, an ENO machine, that can actually measure this inflammation in the airway. And we've been using this device for quite some time in our research protocols, and others have been using it. And now I think the guidelines have sort of opened up to the fact that this could be a good indicator of how well controlled asthma might be. But they are very specific in saying that you know, it can be useful for helping to make the diagnosis of asthma when the diagnosis is in question. So after taking a history, after doing pulmonary function testing, if all of these factors are sort of equivocal, this can be a bonus test to add to your toolbox. And then it can also be helpful to kind of titrate up and down medications, get a good sense of are the asthma symptoms well controlled on the current therapy, and is it time to start thinking about stepping down, or is it out of control and maybe it's time to start thinking about stepping into therapy?
Which brings up, you know, what tests should we do? What is the role of pulmonary function testing, for example? And you know, a test is only as good as the question that we're asking. And in managing the patient, some of the questions that we might have would be, can we stop the medication now? Is the patient seen by history doing well? We do a pulmonary function to see if there's any obstruction. If there's some obstruction, well, we'll be a little more reluctant or maybe step down the medication a little slower. We want to know if they're responding to a bronchodilator. And if a patient is having symptoms that we don't know, we do the pulmonary function test to see really, is this really asthma? Can we tell? If we can see that there's airway obstruction and we give a bronchodilator and we see a response, then that makes a diagnosis of asthma. But there are many conditions where it's not asthma. We can spend some time discussing that.
And as you said, the test is only as good as a question that you asked. Is it also, will the results be actionable? Does it give you any information that, you know, that you can actually use to treat the child?
Yes, as I said, I mean, sometimes if you want to step down the medication, you want to know if there's obstruction, it would help us decide whether we should proceed with reducing the medication. We'd like to know how severe the airway obstruction is. Do we need to step up the medication? We want to know what the response is to a bronchodilator. So we do act on the information that we get.
Anu, there is we talked about the allergy shots, the sublingual tablets and so forth. I understand there's some even more interesting developments in terms of biologics, which we've come to hear, you know, used in terms of asthma and not asthma, but arthritis, psoriasis, cancer, and so forth. Tell me about that when it comes to asthma management.
Yes, so biologics are something that we are using a lot, particularly for those cases of severe or hard to treat asthma, and they can really help minimize oral corticosteroid use, honestly. What they do is they essentially target a specific cell that's involved in asthma, and there's several different options. There's at least 5 that I can think of off the top of my head, but and there's some in the pipeline under investigation currently as we're speaking as well. There are some that specifically target allergic asthma. There are some that target eosinophilic asthma. Some have approval even down to 6 years of age. Some can treat other comorbidities. So if you have a patient that also has horrible eczema, there's probably a good biologic for you. Or let's say the patient that also has chronic urticaria, there's biologics that work for asthma and chronic urticaria, for example. There are some that can even be given at home now, which is a big deal, especially with the pandemic, and it just gives people a little bit more flexibility for sure. So examples that you may have heard of, there's omalizumab, benralizumab, dupilumab, mepolizumab, bresilizumab. So just to throw out some names that might be familiar to you, but it'll really be patient specific which one is the best tool for them.
I've always thought those names sound a little like Daffy Duck talking, but that's another issue. When do you decide, though, to move to biologics, or how do you decide?
That's a great question. So we have some patients that are on a combination high-dose inhaled steroids, and they're not getting better. So that's one example where biologic would be a great option and can really make a difference.
Stephanie, I don't know if this is necessarily the right question for you, but is it your understanding that most pediatric asthma is managed in the community by the pediatrician? And at what point then do you step up to go after or go see a real specialist?
I love that question. I'll definitely take that one. So I think as we sort of alluded to here, there are certain situations where we feel like children who have asthma need just a little bit more care and a little bit more attention that is often difficult to provide in the community pediatric setting. So certainly there are children who have intermittent asthma who rarely use an inhaler or an albuterol medication, short-acting beta agonist, and they often tend to use that just when they're having colds. Those patients, I think, are much easier to manage in community pediatric setting. But when we start thinking about children who have persistent symptoms, who are hospitalized frequently, who any child who actually has persistent asthma should at least once have a pulmonary function test to confirm the diagnosis. And as Meyer mentioned earlier, make sure that they have reversibility with the bronchodilator. Those are kids we definitely want to see in our subspecialty practice, including kids, you know, that have such severe symptoms that we're starting to think about medications like, as Anu mentioned, biologics or immunotherapies, both of which may include injections regularly. Those are also the type of patients that we want to make sure we see and we evaluate and we perform some of these additional testing on, as we've been discussing.
So Susanna, as a kind of a takeoff on that, when should when do you watch and wait, and when do you start to worry, and how do you manage parents who are going to worry and want to escalate sometimes beyond what's warranted?
Yeah, we do. With the breathing issues that come up in our practice in ENT Max, this is what parents want to know. You know, when do I need to worry? When do I need to come in? The short answer is at any time a family or a provider is concerned, regardless of what the symptoms are. If they're concerned and they don't feel like they have a clear answer or a clear plan for management, especially of breathing issues, then they should come and see us. And it doesn't have to always be more than one visit. We could clarify things in one visit sometimes. But anybody who's concerned, should, particularly about a breathing issue, and they want to see, you know, an ENT provider, we're always happy to see them to clarify. In terms of the symptoms that set off my alarm bells in clinic, the first things I always ask parents for any real breathing issue are just the big ones. Has the child ever stopped breathing? Have you ever called 911? Has your baby ever turned blue? Like the key things that get our attention. They don't need to have had that happen now or last month, but have these things ever happened? And then that kind of puts them in a different category for me. In my practice, dealing specifically with a lot of upper airway breathing concerns, I also pay an awful lot of attention to the type of sound that parents are concerned about with breathing. If it's more of a snoring sound, I'm less concerned. Snoring problems with sleep at night that are nasal obstruction, kids will, when they're having enough trouble, wake up and start breathing again. But with that stridor sound, that tends to be more of, you know, a squeak sound that's lower down. It's usually in the glottis or the larynx or below. And that's an area where we have to really figure out what's going on. So if they're describing more of a squeak or a whistle, as opposed to a snore, the type of sound matters to me. And then how often it's happening. If it's something that's on and off, infrequent, and the child is not having major episodes with whatever noisy breathing it is, I'm much more comfortable than a child who's noisy all the time. So it's, you know, sort of the duration, how long, how often, and then the type of sound.
And can I just jump in to say the snoring that Susanna mentioned is something that we often see in pulmonology in our pulmonary practice. We actually have quite a robust sleep center where we evaluate children who have snoring. So if that's a concern, as Susanna mentioned, that the parent really wants an answer to, we can certainly help address that as well.
That's often
As
more
I mentioned,
often obstructive kinds of issues, adenoids, tonsils, and so forth. Meyer.
Yeah, as I mentioned at the beginning, make sure that wheezing is wheezing. So what you're hearing is
Right.
noisy breathing. So what are the other things that we should be thinking about that may not be asthma? Certainly upper airway obstruction, nasal obstruction, that's important. But there's some children who have a chronic cough, and that might be what we call a habit cough. One of the keys points about in the history of making that diagnosis is that the cough is usually very loud and harsh and very disturbing, and yet at night they can sleep through the night without any problem. Another thing that mimics asthma is vocal cord dysfunction. And some people have been hospitalized, some people have been trached for this condition, and basically it's not even asthma. It's really a vocal cord problem, and it's usually related to some psychological issue. And it's very important to make that diagnosis. It's a difficult diagnosis to make. Both Susanna and I see this. If they're not making the noise at the time of, or not having any sort of noisy breathing at the time of the exam, you can't make the diagnosis. So you just have to have a high index of suspicion.
Adriana, yes.
No, I was just going to say, just to clarify that, because I think that particular diagnosis, the vocal fold dysfunction, it's a really hard one to tease out. I saw this in my clinic today, a really classic example. So just to give some specifics to clue people in to the fact that this might be the issue, it tends to be something that's induced often by exercise or severe exertion or anxiety or stress. It's a self-limited thing. Like they have very, very noisy breathing, stridor for after the trigger for a limited time, and then it gets better on its own. Like treatments like steroids, inhalers won't help. And it's usually in the age group. If you're seeing an adolescent or young teenager who might be an athlete, that's like the classic picture for vocal fold paralysis. Or sorry, dysfunction, not paralysis. Vocal fold dysfunction. Yeah.
Got it. Adriana, let me ask you, do you sometimes see in the community setting the inverse of what Susanna was talking about, the very worried parent? Do you sometimes see parents who say, well, it's just a cough, or, he makes noise or she makes noise and he's fine, and you have to sort of ease them into the thought that this might be something that's a little more serious, and how do you do that?
Absolutely. I think, unfortunately, many of our families get used to the cough, and it's just part of their everyday. So to them, it's not something that's abnormal.
Right.
And so sort of stepping back with them and saying, let's normalize this. Actually, this is not normal. And it's normal for a child to cough when they have a runny nose, or they're sick because they have an ear infection, congestion, or a sinusitis. But that's a discrete episode that should last maybe 10, 14 days, depending on whether or not you're getting antibiotics and such. But when you hear from parents saying, oh, she coughs all the time, but that's not asthma. And they'll often say to me, he coughs all the time, but that's not asthma. Then I know I have to go back to the basics and really get into an understanding of the definition of how it can present, also their quality of life, and really maybe approach it from a different angle in terms of what's the impact on the family that this child is coughing all night. So bringing them on board to their impact in their home. Maybe mom is tired every day going to work or missing work, right? And so really thinking about it from a different approach really often helps bring them on board to that diagnosis. So, and that can take time. And that's what I was referring to before, building that trust and understanding. Some folks come into the office ready to sort of battle me and say, it's not asthma. Every kid who comes in here comes out with a diagnosis of asthma. And so we really need to sort of de-escalate that and build that trust to get to the place of potentially diagnosing the asthma, starting a controller, and then changing their world, right? Because then there are quiet nights of sleep, mom goes to work, child goes to school. And sort of painting that journey for them, but that again takes time and building on that relationship.
Boy, it so often comes down to relationships and communication, doesn't it? Regardless of what we're talking about. Speaking of which, I know when it comes to things like controlling whether it's allergies or things, is there an issue with getting schools now and school nurses, et cetera, to be able to administer things in case there's an emergency, or if they need some sort of ongoing medication in school? That just dawned on me that that's been an issue before, particularly with things like EpiPens, but for breathing problems and allergies and asthma.
Right. So besides food allergies, we also often give action plans for asthma. We have some patients where it's difficult for the parent to give the inhaler in the morning, or there's some kind of other issue. And in those kind of situations, exactly as Susanna said earlier, we'll get the school nurse on board as well. And oftentimes these kids will at least get their first dose of that inhaler at school, which kind of guarantees that it's happening, and it's makes it easier for the family as well.
So Stephanie, one other thing that you mentioned that caught my interest, bronchial thermoplasty. That sounds like a nuclear option. Tell me about that.
I skimmed over that one real quickly.
I'm paying attention.
And the reason why is because it's actually not recommended. So bronchial thermoplasty has been around for a little bit more than a decade or so, I would say, but it tends to be a treatment option for the most severe of cases and in adults. So these updated guidelines have strongly recommended against using it, particularly for individuals younger than 18 years of age. So if you hear about it, you know, it's not quite ready for prime time in our pediatric audience.
Look for some other options first.
Yeah.
Got it. Meyer, HEPA filters have been, and air filters of one sort or another, have been mentioned a couple of times already. How effective are those? And they can be expensive. And so how do we get that into the hands of people who really need it but may not be able to afford it?
Yeah, I think that, you know, HEPA filters have been shown to work for some things. It's certainly, if you have a pet in the house, it can reduce the amount of dander that's an allergen that's floating in the air. If there's cigarette smoke in the house, it does help that as well. If there's mold, it can help that. But, you know, all these things that I'm mentioning, there are other ways of reducing the exposure, right? You don't want people to smoke in the home. You don't want, if there's mold will grow if there's a water leak, so you have to fix the leak. So there's other things. But I think that if the child is quite allergic, it's probably, and we know what allergen, it's not going to help with so much with dust mites. But it will help with, if they want to keep the pet, it's probably a good idea to have the HEPA filter. How to get a cheap HEPA filter, I can't answer that question.
Are there community resources at all that can help families with that?
Adriana might answer that.
So not to my knowledge as far as HEPA filters, there are other, sort of along the line of the conversation, other resources like integrated pest management that some local Department of Health are sponsoring programs to bring into the home of some of these families an environmental assessor who can not only remediate the issue, whether it's the leaky pipes that Meyer was talking about, or the tremendous rodent problem by plugging holes in walls, but also bringing in advocacy to help with landlords and housing. So there are sort of other interests that are other resources that are out there that can help families, particularly in urban areas, because we've seen an impact in that remediation.
And I imagine those kinds of assessors are also really useful because a family or individuals may not always be able to tell where the problem is or what the problem is.
Absolutely. And they also often maybe in my experience, have been misinformed by maybe the housing authority or the landlords who say, oh, just clean that area, wipe it with some Clorox, and it'll be fine. And again, to Meyer's point, you've got to understand what's happening behind that wall and fix that leaky pipe, or else within 2 months, the mold is back. So it's really supporting folks in their ability to demand, and really speak up for their rights. And programs do exist in local jurisdictions for that.
And by the way, Meyer, I've yet to run into a family who was willing to get rid of their pet.
Yeah, I mean, I'd prefer to get rid of their child. That's the first option. But yeah, so I mean, that's where I think, you know, you can tell that a HEPA filter is important. Now, there's some people, I mean, if the child is really having a problem, you know, with the allergist and with, you know, with discussion with the parents, but it's very rare that you, at least from my practice, that I have to tell them to get rid of the pet. I don't know, Anu, what do you think? Do you tell them to get rid of the pet?
I never tell people to get rid of a pet because I know how important they are to people's family, but they are sometimes indeed problematic. One pearl I will say is there's no such thing as a hypoallergenic cat or dog. So if you're allergic, you could be allergic to the skin, you can be allergic to the saliva. So I would be very cautious about getting a pet in someone that is allergic to it. But just to add also, this might be a good situation where subcutaneous immunotherapy is a good option. And for those families that have the pet, they have no intention of getting rid of it, and the kid has horrible symptoms. At that point, sometimes you just need to do a little bit more, and it helps. And after therapy, a lot of people are able to be around the pet, and it doesn't cause as significant issues anymore.
Probably a better option than getting rid of the pet, I suspect. Susanna, what would be the sort of algorithm, if you will, that say the community pediatrician might want to start with to determine what's causing the child's problem? We can, before we get into really subspecialty testing and so forth, what are the steps you think that a community pediatrician should be asking child and especially parent to figure out what's going on?
Yeah, I think the first, branch point to figure out is the issue a minor one, or is this something that, is really serious or life-threatening? And that just circles back to the symptoms I mentioned before, that those big sort of three, the turning blue, stopping breathing. Have you ever had to call an ambulance for this issue? And, when it comes to breathing issues, I'm sort of walking down this algorithm often. I start there, and then I try to figure out, like I said before, what's the timing of the issue? How long has it been happening before? How often is it happening? Is this a daily problem? Is this something that is happening only sometimes? And then are there triggers for the issue that help us figure out which road are we going down? Is this something that, is related perhaps to reflux issue? Was there an upper respiratory infection that sparked this problem? Does the child have, or is there a family history of allergy or asthma or things that could be related? And then, we get those clues when it's not clear. And I think the water can be kind of muddied a lot of the time. I feel like this is the reason why we have programs that are multidisciplinary. A lot of times I need the input and the feedback from other providers in pulmonary and gastroenterology and allergy and other services. And so we've got multidisciplinary teams where if there's an issue with breathing or with coughing that's not an emergency, but it's still not clear what it is, then seeking out, a care team that maybe has a few different providers can be a really helpful thing. So if pediatricians can know that we've got, an aerodigestive program, there is a comprehensive asthma management program. These are things that people can seek out that can help do the diagnostic testing to find out what's going on. And sometimes, and it's not most of the time, it's in rare cases, but sometimes we have to go to the extent of, taking a trip to the operating room to look at the airway, to look at the tracheobronchial tree, to look at the digestive tract all together. And that's with me, with a pulmonologist like Stephanie or Maya, with a gastroenterologist, to look and really see and do a little bit of testing to figure out what is the primary driving force. Is this a digestive issue? Is there an anatomy problem? Is there a pulmonary problem or an infectious problem that is causing these issues?
So as you were saying that, something just suddenly dawned on me. Since virtually everybody these days has a smartphone, right? And we talked a little bit about, is it a wheeze? Is it a real wheeze? Is it snorkeling? Is it snoring? Would it be helpful for, mom or dad when the child is doing that, particularly sleeping, to grab the phone and do a little recording and bring
All
it in
the
and say, here's
time.
what they sound like?
I love it. That is so, so helpful. And a lot of parents know to do that. Do you guys see that too? Are people bringing in videos? Do you guys find
Yeah.
them helpful? So
Parents,
helpful.
some parents volunteer. It says they said I've recorded it and they show it. Other people, I tell them to do it and they say, oh, that's a good idea, and then they bring it back.
I have a quick question for Anu, and then fair warning to our panelists, because what I like to do at the end here as we're wrapping up is to ask each of you for a very brief take-home message, the nugget of wisdom that you want our webinarees to take home. But Anu, real quickly, a question came in asking, does it help to wash the pet, shampoo them down to take down some of the allergens?
That could be a strategy. I don't think it'll be completely helpful, but you could try it and hope it helps. But I don't know how much evidence there is for that specifically. But certainly doing things like if the dog is already or animal is already part of the home, making sure it's not in the child's bedroom, it does not sleep on the child's bed.
Right.
So just changing the home environment a little bit makes a difference.
Yeah. You could end up with a cranky cat or dog too if you're doing that very often. Let's start with, if I may, Stephanie, would you like to give us your words of wisdom here to take home?
Absolutely. I think asthma is a complex problem, and there are a lot of different strategies to management, and there are a lot of different components that need to be addressed. So I think that my advice would be, if you have a child in your practice who has asthma and you're feeling like you're a little bit strapped for time, please don't hesitate to refer them to a pulmonologist or allergist or someone as part of our team, and we'll get them connected and try to help you with managing their asthma.
Adriana, you're up next.
For me, I think I go back to sleep. And this may surprise some of you all, but I think if we, as a general pediatrician, if we don't ask about sleep, parents may not be as forthcoming. That's where things like the reflux may come in, the cough because it's asthma. So again, not taking that one for granted and really being very targeted with our history around sleep. It tells you a lot.
Susanna? What should we hear?
Yeah, I would want everybody to just know that that we're here. We've got multidisciplinary programs, and in particular with this issue of cough that we've been talking about, even something as simple or as basic as that seems like a minor issue. A cough isn't necessarily just a cough. And if there's an issue like that that's persisting, that's not getting better, then by all means, we're here. And sometimes these are difficult things to sort out, and we can help with that.
Terrific. Anu, tell us, what should we remember?
So I would say that rhinitis is certainly important to control, because it's one of those things that can contribute to cough and really affect someone's quality of life. So understanding if there's allergic triggers to that is important, and just knowing that specifically identifying it is useful too. So if someone actually only has an allergen that is prevalent in the springtime, for instance, like maybe they don't need to be on allergy medicine the whole year. And one last thing I will say too is, if you're treating rhinitis, make sure you're using a treatment that's actually going to their nose, because that is the best way to target it, instead of using something like oral antihistamines.
Got it. And Meyer, as the senior member, which means, like me, that you have gray hair, but also you're the chief, you get the last word.
Yeah. Well, I want to thank the panelists for their insight. My feeling is that it's not normal for a child to cough for weeks and weeks. Okay. And we should want better for the child. And it's important to get a very detailed history. And if it becomes complicated, we have a little more time to get that history and to try to sort it out. And we have a few more resources, and that's where we can help out.
Terrific. I also want to thank all of our panelists. It's been really informative. I think we've had lots of very important information, not just for our pediatricians, but also for parents who are listening in. A summary of some of the information from tonight that will be sent out to our registrants, and these videos of this video will be available on the Columbia University Irving Medical Center YouTube channel. Thank you all, and stay safe and wear a mask, please.
Bye-bye.
Bye-bye.